In the previous two lectures, we talked about the history of epidemiology and the connection between epi and biostats. And we looked at a couple of examples of epidemiology and biostatistics at work. The first one, the food outbreak at the picnic, and the second was the case of Susser syndrome. In both of those examples, we used something called a case control study design. There was an infectious disease outbreak. We identified cases, we identified people without the disease, the controls, and then we looked back at exposures. But that's only one type of epidemiologic study design. And so today I'm going to introduce you to several others, which can be used for both infectious and non-infectious diseases. So the two major brackets, if we're looking at that in epidemiology, are observational studies and experimental studies. The difference here is that in observational studies, the researcher, you, are just observing the behaviors and the outcomes. You're not doing anything to influence them, or at least you're trying not to. In experimental studies, you as the researcher are controlling the exposure. Okay? You want to affect a difference in the outcome, and therefore you want to change what the exposures are. So within observational studies, you look to see first, is there a comparison group? If there's no comparison group, then you're looking at something like case series or cross-sectional or ecological studies, and these are also called descriptive studies. If there are comparison groups, then you're looking at analytic studies, case control or cohort. These are studies in which you can take your outcomes and make inferences about what you would think would happen in other populations that have yet to be studied. In experimental studies, there are almost always a comparison group. Now, sometimes that's a separate comparison group, and sometimes it's called a quasi-experimental, where you're comparing something pre and post-intervention. And these are called intervention trials, field studies, and clinical trials. So let's look at first at case reports and case series. In these types of studies, a researcher, often a physician, describes the experience of either a single patient or a group of patients with similar symptoms and therefore diagnoses. And these are often used as the basis of discovering new diseases or new disease patterns. And it's often used for rare diseases or emerging diseases. So an example of a case report which led to a case series is HIV/AIDS. So we're in the early 1980s, between October of 1980 and May of 1981, there were a handful of cases of this particular type of pneumonia, which was being reported amongst otherwise previously healthy homosexual men in Los Angeles. And previously, this only really was seen in older immunosuppressed cancer patients. Likewise, in 1981, there was an unprecedented number of a particular type of cancer called Kaposi sarcoma, which were being diagnosed in young homosexual men, but had previously only been seen in the elderly and amongst men and women equally. And the physicians treating these individuals saw that this was different than what you would normally expect and started writing up these case reports in these case series and having them published so that other people could see if they were noticing a similar pattern, and an effort to develop a hypothesis about why this might be. And that led to the first sort of idea of what HIV/AIDS would be. At that time, it was originally called, or it was originally thought to be just amongst homosexual men, and because of the reporting, it began to be recognized that this went beyond young homosexual men into other populations like hemophiliacs, etc., and allowed us to really begin to understand the etiology and transmission of HIV and AIDS. So the advantages of case reports and case series is that they really are great for hypothesis generation, and they're important often first step in recognizing new diseases or risk factors. The disadvantage is that they're based on the experience of one individual. If one physician happens to see 5 cases, but chooses not to write them up, we may not know about it, or it may take much longer to understand and identify those conditions. And because they're based on the experiences of particular individuals, you can't test for valid statistical association. The experiences of those individuals are particular to those individuals, both the patients and the researcher. And so all we could do is describe what's happening and say what we think might be causing it. If we're looking at a hierarchy of study design, the next level up would be an ecological study. And this compares population characteristics across group levels, across the groups. And it's, again, useful for generating hypotheses and looking at higher level variables such as social or environmental factors. And so, for example, you have two different populations, and over here, one population on average eats a healthier diet, and the second population eats an unhealthier diet. We can tell that by food sales and per capita consumption, and then we might look at heart disease rates. And again, that's overall. Now, ecological fallacy is when you try to apply these population level data to individuals. So, while as a whole, these individuals may be healthier and these individuals may be less healthy, because it's population level data, there's no way of knowing exactly whom within this population ate the healthy diet. And it's entirely possible that there are several people in this population who are eating a healthy diet, and you don't know who they are. Again, this is at the population level. And so, for example, in 1975, researchers mapped national breast cancer death rates and different patterns of intake for food. So this, they looked at both animal and vegetable fat and total fat consumption per capita. And what they found was that, on average, countries that reported per capita higher animal fat intakes also reported higher age-adjusted death rates. So as you went up, that went up. Now, this led to the hypothesis there may be an association between diet and breast cancer. Now, when we went on and did additional studies, this particular association did not seem to hold as well in other study designs, but it really opened up the idea that there are environmental factors at play. The advantages of ecological studies, they tend to be relatively quick and inexpensive because for the most part the data has already been collected, typically for other reasons, and you're just looking at whether or not they're associated. It allows for the estimation of effects that are not easily measurable for individuals in often cases, and it begins the exploratory analysis of potential etiologic factors. So it takes some of the hypotheses and allows you to explore them a little bit further. The disadvantages, we already talked about ecological fallacy, trying to say that this population level data tells us something about those individuals within the population, and it's difficult to control for confounders. So, are the individuals in these countries, is it the animal fat, or are they smokers? What's the smoking rate? How can we control for that? Are the age ranges different? Are these happening, we're seeing these more among older women and this is younger women? So what's the population distribution? What are their other behaviors? It's very difficult and sometimes impossible to control for that for two reasons. One, statistically, it's very challenging, but also that data might not be available. Cross-sectional studies are similar to ecological studies in that we're collecting data from a population. We're doing these surveys. So somebody comes into, for example, a classroom and hands you a survey. They're not asking you about your disease status and then separating you into groups and trying to identify enough of you. They just want a snapshot of what's happening in that classroom at any given time. So cross-sectional studies is looking at one group at one point in time and is assessing exposure and disease at the same time. And so we're looking for here, do you have the disease? Do you have the exposure? And we're not selecting on either of those factors. And that's really key because in the other study designs we're going to be discussing, participant selection is based either on disease status, as with case control studies, or exposure status. And these types of studies are really good for data collection at the individual level for both disease and exposure or risks. So whereas ecological studies were done sort of a snapshot in time for populations, these are snapshots in time for individuals. And they more often result in more complete data collection. If you're asking somebody to complete one survey, particularly if you're in the room, you're more likely to get complete survey than if you're trying to follow people up over several years. The disadvantage, you can have something called survivor bias. So the only people who are in the study are people who've lived long enough. If you have a disease that is highly fatal and individuals are contracting it and dying quickly, they're less likely to make it into your study. You're sort of missing that snapshot. In addition, there's no temporality. And so if we want to know if a particular risk factor caused a particular disease to happen or an outcome to happen, we need to be 100% sure that the exposure preceded the disease. But since we are doing this as a snapshot in time, we can ask about past history, but because as we know the disease process, especially for chronic diseases, have a long latency, it gets very difficult to establish temporality. Which came first, the exposure or the outcome? So moving from descriptive to analytic studies, we have our case control study, and we've talked about this twice now. In these studies, you have two groups, and you're recruiting or selecting participants based on the disease or the outcome, and then you're looking back at time. So individuals who have that outcome are labeled as cases, and individuals who do not have that outcome are controls. And you're asking them to recall their exposures in the past. And so what you're looking at is you're comparing the prevalence of the exposure and cases and controls. All exposure information is measured retrospectively, meaning it already happened. We're talking about past exposures. And when we're looking at the study, the measures of association, we've now actually gone through this. We're looking at how do you measure your odds ratio. So we have our A, B, C, D boxes in our standard 2x2 table. So outcome, yes, no, exposed, yes, no. And you're looking at the odds of exposure amongst the diseased and the odds of exposure amongst the non-diseased, or in this case, your handy dandy AD divided by BC. So if we look at alcohol consumption and esophageal cancer, there were 200 cases, 200 controls. Of the cases, 160 consumed alcohol, and of the controls, only 90 did. So the odds of exposure amongst the cases is 4. The odds of exposure amongst controls, 0.82. So we can already tell that they're going to be, there's some difference happening there. So the next step would be to divide the odds of exposure amongst the cases divided by the odds of exposure amongst controls, and you get 4.88. This means individuals who have esophageal cancer in this population were almost 4.9 times as likely to have consumed alcohol. Or you could also say they're 488% more likely. If you just do the ADBC, you see that it comes out fairly similar, 4.89. You would say here there's an increased risk of esophageal cancer associated with alcohol consumption. So that's an increased risk. The advantages of case control study are that you can ascertain the cases quickly, right? Because you're looking for those diseases, you're not waiting for them to happen. And they tend to be useful for rare diseases. So you saw in the case of Susser, it was a rare condition. If you were doing a cross-sectional study, the probability of picking those individuals up would be very difficult. But If we know where the cases are, we can simply define our cases, identify them, and interview them. There are several disadvantages. One is recall bias. And what this says is we all misremember things. The human mind is notorious for misremembering. And so, for example, if we ask individuals to say everything that they ate yesterday, a lot of people would say, wow, I think I know. I don't remember. What did I have for breakfast? And in case control studies, we're often asking people to recall not just what they did yesterday, but what they did several years ago. And everybody makes mistakes there, and we know that. The problem with recall bias, which is different than recall error, is that individuals who have a particular adverse outcome, a disease, for example, are going to remember things differently. So the example that's often used to really highlight the difference in recall bias is if you have a new mother or two new mothers. One just had a perfectly typical birth experience and birth outcome and now has a healthy infant. The other had, unfortunately, an atypical birth experience and birth outcome and now has an infant with some disease or some condition. The mother of the infant who was born with some sort of congenital disease is going to recall their experiences during pregnancy differently. They are going to sit and wonder and worry and remember and ruminate on every single aspect of their pregnancy in a way that the mother of a healthy infant is not. And so because we have a disease or condition, we recall things differently, and that's called recall bias. And there are ways to try to control for recall bias, both methodologically and statistically, but it's something that always underlines case control studies and concerns we have. The other is selection bias, making sure that we're not selecting our cases and controls based on their exposures. And so who joins the study? How are they different from people who are not part of your study? It's generally, but not always the case, that it can be very difficult to assess incidence or prevalence depending on the disease outcome. So I do cancer research in many of the states, but not all of them. There is a cancer registry, meaning as soon as somebody is diagnosed with cancer, the physician reports that to the state registry, and we know a new case has been diagnosed. So it's a little bit easier to diagnose, to get incidence data for certain cancers, depending on where you are. More often what you're getting is prevalence. These are everybody who exists, and you're just finding them, right? So they may not be a new case, it may be that you're just identifying them now. And control selection can be challenging. If you recall from Susser, you want your controls to be as close to your cases as possible, but they simply don't have the disease or don't have it yet. They could have it. So I believe I used this analogy or this example once before, where you do not want to have a case control study of prostate cancer where your cases are men and your controls are women, because women can never get prostate cancer. So you need your cases to also be controls. And you also need your controls to come from the same population as your cases. So if you're getting all of your cases from one hospital, you should get all of your controls from that same hospital. If you're getting all of your cases from the general population, your controls can come from the general population. The other problem is individuals who are otherwise healthy are less likely to participate in research studies. Individuals who are sick, who have a particular disease, want to participate because they generally want to understand. So it's important that we do a good job selecting our controls, but it's one of the more challenging aspects of case control studies. The other analytic study design, which is also observational, we're not intervening in any way, are cohort studies. In this case, you also have two groups of individuals, so two separate groups within a population, but instead of identifying them based on their disease status, you're identifying them and categorizing them on their exposure. So these are individuals who do not yet have the disease, and we're asking them, do you have this exposure? Yes or no, or what levels of the exposure have you had? And then we're following them forward in time to find out, do they develop the disease or outcome, or do they change their behavior in some way? And so an example of this is the Nurses' Health Study, which is conducted out of Harvard University, the Chan School of Public Health. It's been ongoing for well over a decade now, probably closer to 25 years. And they identified women, nurses in this case, throughout the country who were healthy and disease-free for the most part at the beginning of the study, and they asked them about a number of different exposures. So Walt Willett and Ed Giovannucci, for those of you who are nutrition students, really took up this study and looked at nutritional risk factors for different outcomes. And there are several researchers who work on the study. But they looked at things like, is there an association between different food consumption, animal fat versus vegetable fat, etc.? And they've been following these women forward in time, and they follow up with them. And sometimes it's a survey, and sometimes they ask them to send back blood measures or biometrics like their weight or their waist to hip ratio, etc. And they follow them up, and they see who develops the disease and who doesn't. And because of this, because of the way this study is set up, we know that the exposure is coming before the disease. Now, depending on the disease, it's going to determine how long you need to follow up for. Because if you are starting with people who are in their early 20s and you're interested in, say, breast cancer, you need to be prepared to follow them up for 10, 20, 30 years. If you are looking for other diseases where there's a shorter latency period or we're starting later, that follow-up time may be more or less. So the big advantage is temporality. You know that this exposure is preceding the disease because you're selecting a disease-free population, and you're getting true incidence rates. They were disease-free, they now have the disease, you know that's a new case. And they're very good for rare exposures. So another example of a cohort study is one that has taken place post 9/11, looking at individuals who were both living in the area around Ground Zero in Manhattan and those who worked on Ground Zero thereafter. And that is thankfully a rare exposure to a lot of toxic chemicals and significant changes in the physical environment. And those individuals have now been followed post 9/11 to look at incidents of primarily or largely lung disease and respiratory cancers. But there have also been some studies that looked, for example, at distance from the initial Ground Zero site, and they followed pregnant women in the area and looked at pregnancy and birth outcomes. So it's good for those rare exposures. Things that you can't anticipate happening, they happen, and now you're following them forward to see what the results are. The disadvantages, they take a lot of time. You're following individuals, again, for months, years, or decades, and time means money. They're expensive to do. It is hard to follow up people, and if you want to do a good job of not losing people, you have to invest a lot of time and money. One population that is particularly difficult to follow up with tends to be young women, because they tend to do things like get married, and in this country, often, but not always the case, change their last name. And so if you change your last name and you move, it makes it a lot harder to find you. And researchers have a number of techniques to try to combat that. So we ask for your now email, multiple phone numbers, as well as people who will be able to find you. So a close relative or friend who, even if you move, we can contact them to get in touch with you. But there's always the risk of loss to follow-up bias, that there's something about either your exposure or non-exposure status that leads you to be lost to follow-up. And so if we notice that those individuals who we can't find, were materially different, or in some ways clinically significantly different from people who were not lost based on the data we already have at baseline, there's the possibility that there's some loss to follow-up bias. And unlike case control studies, which are good for studying rare diseases, these are not good for studying rare diseases. You're starting with people who don't have the disease and you're waiting for them to develop it. And so if you're trying to look at rare diseases, that means you have to have a larger population to increase the probability that you will get those cases in your population, or you need to be very strategic and really looking at high risk groups to follow up. Either way, it's much more difficult, and in some cases it becomes almost impossible to do. Now we're moving from the left hand of the screen, from those observational studies, to the right hand, the experimental studies. And the difference between a cohort study, those prospective cohort studies, and a trial or an experiment is that in this case, you, the researcher, is assigning the exposure status. So again, you have two or more groups created either by a random or non-random selection process, and then you're assigning them to be exposed or unexposed and following them forward in time. So these are all people who should be disease or outcome free, and you're telling them what their exposure will be. So even if they're currently exposed or unexposed, you're altering that. So there are several advantages. One, you as the investigator are controlling the amount, timing, and frequency of the exposure. So you have a lot of control. So you can really look at the association between that exposure and the outcome. And again, it's disease-free, so you're getting that temporality. And in this case, because you're assigning the exposure, you can now start to talk about terms not just as associated, but causing. If you're using randomization, so you're randomly assigning people to either have the exposure or not, it reduces the likelihood that noise gets in, that these other factors might really be the problem. So confounding is when there's a third variable that's influencing the disease that you may or may not be accounting for. So for example, there's an association between gambling and lung cancer. And there were studies that recognized, hey, there's this pattern that people who gamble, people who spend a lot of time in casinos, are more likely to later be diagnosed with lung cancer. Well, biologically, is there a reason why gambling itself should cause lung cancer? So we know there's an increased risk. We know there's some, measurable association. But why is that? Well, that's because there's a third variable that was not being accounted for. Exposure to smoke. So individuals who spend time in casinos are more likely to be exposed to either their own smoking behavior, so they're more likely to be smokers, and for people who are non-smokers, they were more likely to be exposed to secondhand smoke. We know that smoking and exposure to tobacco products and the smoke increase your risk of lung cancer. And so in this case, there was a third variable that was associated both with our exposure, gambling, and our outcome, lung cancer. And that's what confounding is. In experimental studies, all those other variables, age and race and gender, should be, if you're randomly selecting your population, evenly distributed in your exposed and unexposed groups. And therefore, you really shouldn't have to worry about them. They're controlled for. In these studies, we often use something called blinding. So the participant may or may not know what their exposure has, what exposure they have, depending on the exposure. So this is often used in drug trials where you have a placebo. And so one person is getting the medication and the other one is getting a placebo or the standard of care versus the newer medication, and then they're followed up. You can have single blind where the participant doesn't know, and you can have double blind where the participant doesn't know and the person who's doing the follow-up, the researcher, they also don't know. And it's not until the end of the study that you unblind it and everybody sees who had which exposure. And by doing that, you make sure that there's no bias in follow-up. So if I know person A has my exposure of interest and person B doesn't, it keeps me from, blinding would keep me from following up and being more diligent or probing more with patient A. Are you sure you haven't had any symptoms? Let me check one more time. Let me run more blood work. If I'm blinded and I don't know who has the new drug and who doesn't, I'm more likely to follow up with them equitably. That being said, almost everybody tries to guess which exposure they have. And in some cases, it's simply not feasible. If you're testing a new curriculum, it's obvious who has which curriculum. And that's okay. You just have to be aware that your protocol is such that you're not following up differentially. The limitations are much more expensive because you now not only have to follow people up over time, but you have to be able to provide whatever the exposure is, and placebo development can be very challenging as well and expensive. Recruitment can be difficult. Often people don't want to be at risk of getting the placebo. And for clinical trials, for that reason, you often start with the sickest of the sick. So people for whom standard of care is no longer working and they're really willing to try the experimental studies. But again, it's very difficult to get people into these studies overall. And obviously, you cannot use it for what you know to be potentially harmful exposures. Now, there have been cases where people have been given exposures as part of a research trial that they thought would be beneficial but did turn out to be harmful. So one example of this were some beta-carotene trials that were taking place. There were two, the ATBC and the CARROT study. One was in the US, one was in Europe. And based on case control studies, there was this seeming association between smoking and particular cancers, beyond lung cancer even. And what some ecological studies noted that there were also an association between low carotenoid intakes and these cancers. And so they started with smokers in this Finnish trial, and they gave these massively high doses of beta carotene to smokers and followed them up, thinking that those who had very high doses would reduce their risk of developing lung cancer and esophageal cancer and some other cancers. And the trial was supposed to last several years. Halfway through, what they do is they'll unblind, they'll sort of take a peek to see, is everything going in the direction we think it is? And what they found was it wasn't. It was actually going in the exact opposite. Those massive doses, individuals who got the massively high doses of beta carotene were actually being diagnosed and dying at higher rates than those who weren't. At which point, this is why we have those, peaks, those unblindings. The trial was stopped, the exposures were stopped, and individuals were simply followed up. It changed from an experimental study to an observational study. And we did learn from that. We learned that while low levels of beta carotene, if you're undernourished, bringing you back up to where you should be can reduce your risk. In well-nourished populations, beta carotene can suddenly start acting not as an antioxidant, but a pro-oxidant, and can actually increase your risk. And so we did not know, the individuals did not know that that would happen, so that was not unethical. Unethical would be, we know smoking causes lung cancer, and I cannot divide this class and say, you are now going to smoke, this half will smoke 2 packs a day and the other half will be non-smokers. We know that's a harmful exposure. It would be unethical to assign that exposure. And so the measure of association for a cohort or experimental study is a little bit different than that for a cross-sectional or case control. Cross-sectional and case control, we use odds ratios. And cohort, what we're looking at is not the odds of exposure amongst cases over the odds of exposure amongst control, but the incident rate amongst the exposed over the incident rate amongst the unexposed. So instead of looking down the columns, we're looking across the rows. So of everybody who was exposed, how many had the outcome? And of everybody who was not exposed, how many had the outcome? So in this case, it's A divided by your total, A plus B, and C divided by your total, C plus D. So if we're looking at physical activity versus no physical activity and heart disease, the incidence rate the incidence of heart disease amongst people who are physically active is 0.17. The incidence rate amongst people who are not physically active is 0.4. You divide that and you get something called a relative risk. That's 0.42. So as you notice, this is below 1. When we're looking at odds ratios or relative risks, we're comparing it to 1. If the top is equal to the bottom, your relative risk should be 1. That means there's no association. If it's above 1, as we've seen, say between alcohol and esophageal, there's an increased risk. And if it's less than 1, there's a decreased risk. So what this is saying is that individuals who are physically active are less likely to be diagnosed with heart disease. And they're less likely by about 60%. And then we're comparing this to 1. But what if you want to look at more than one variable? For example, the amount of physical activity. So you have no physical activity, less than 30 minutes a day, or more than 30 minutes a day. Well, we in epidemiology and biostats like to make 2x2 tables. This is not 2x2. So what you would do is look at it into 2, you separate them. And we'd want to compare both of these to no physical activity. So is some physical activity better than nothing? Or do you need really more than 30 to see the benefit? So we have heart disease, no heart disease, you're exposed to physical activity versus not. And then same thing, but now your exposure is more than 30 minutes a day. And then you do your calculations. So for each table, here we see, well, would you look at that? The incidence rate amongst people who have less than 30 minutes a day is the exact same as the incidence rate amongst people who have no physical activity at all. So getting less than 30 minutes per day is not associated with heart disease risk compared to people without physical activity. So there's no association between low-level physical activity and heart disease risk. Or being physically active less than 30 minutes a day does not lower your risk of heart disease compared to no physical activity. But what if you're physically active more than 30 minutes a day, which is what the recommendations say? Well, that's pretty different, right? So now it's 0.25, which says being physically active more than 30 minutes a day is associated with a lower risk of heart disease compared to no physical activity. And in this case, you're 75% less likely to be diagnosed with heart disease if you exercise more than 30 minutes per day compared to not being physically active at all in this population. And you could, if you wanted, create a third table where you look at more than 30 minutes a day compared to less than 30 minutes a day to see if there's any difference there. So which design is best? There's no answer to that. The design that's best is the one that matches your question the best. So if you were looking at a rare outcome, you might want to pick a case control study. If you have a rare exposure, a cohort study. If you're just beginning to understand what you're even thinking about, if there's a new hypothesis based on an ecological study, you're not automatically going to jump to a trial. That's expensive. Cohort studies are expensive, so you might do a cross-sectional study. Or you might be looking to generate hypotheses about a number of exposures and a number of outcomes all at the same time. And trials are good when you have a firm understanding, when you think you know what's happening and you want to test that hypothesis. So that's really good for hypothesis testing. Which is the fastest? That's easy, cross-sectional. They're surveys. They're done one point in time, typically, and you can often gather a lot of data in a very short amount of time. Which is the most expensive? In this case, clinical trials or experimental studies. So as you go down this list, it's going to get more expensive. as you go up, it gets less expensive. Which has the most accurate exposure assessment? Again, this is going to be a trial because you as the researcher are controlling the exposure assessment, right? So you're telling them what their exposure will be. Now, not everybody will be compliant, but you have a much better sense, depending on the setting, than if you're doing a cross-sectional case control or cohort study when you're asking people to report that back. And overall, the gold standard are typically trials. Again, they're highly controlled, you're controlling the exposure, monitoring carefully for the outcome, and you're doing all those things because they're expensive. And it doesn't make sense to invest a lot of time and money and energy if you're not going to be very controlled and very careful about your follow-up. That being said, a trial is not, as we said, appropriate for every research question that we have. And so as you go forward and as you do the homework assignments, you're going to want to try to pick, you have to pick 2 case studies or examples that you're going to work through, and you're going to see how these different study designs play out, similar to the way we did when we worked through the outbreak of foodborne illness and Susser. And you can really get a sense of what these studies are and what their strengths and weaknesses are. So just to recap, because this is something that students often struggle with, if you're looking at different odds ratios, what do they mean? So how do you interpret them? So there was this hypothetical study that was done that was looking at a number of risk factors or potential exposures and whether or not you were admitted to college. And so they found that female gender versus male, the odds ratio was 1.4. What this means is that those who identified as female were 1.4 times as likely to be admitted to college compared to men, or those who identified as male. Or you can say they were 40% more likely. Individuals who consumed alcohol compared to those who did not were less likely. Again, this is under 1, so they were less likely, or about 50% less likely to be admitted to college. If you are sedentary, meaning you're not very physically active, there's no association with college admissions. So what do you think about smoking? Are smokers more or less likely to be admitted to college? Well, the number is less than 1, and it's pretty far away from 1. So smokers are less likely to be admitted to college. They're about 60% less likely. And illicit drug users are even less likely to be admitted to college. That being said, individuals who participate in regular sports practice are much more likely to be admitted to college, right? So that's bigger than 1. They're 2.1 times as likely. So it's important that you understand that, and we'll practice that, and you'll get some practice in your homework assignments as well. But I will tell you, for the exam and going forward in public health, it's important that you know how to interpret those risk factors. You would interpret an odds ratio the same way that you would a relative risk or an attack rate. The comparison is always to 1. If you're doing rate differences, you're not comparing to 1, you're comparing to 0. Right? So if you're subtracting, if the difference is 0, there's no difference. If you're dividing and the difference is 1, then there's no difference. So perhaps you have this example in front of you. Right? So we're looking at obesity and fruit and vegetable consumption. And compared to no fruit or vegetable consumption, individuals who consume 5 to 9 servings of fruits and vegetables a day have an odds ratio of 0.8, and those who consume more than 9 servings a day have an odds ratio of 0.5. How do you interpret those findings? I'm not going to give you the answer. I'm going to allow you to put that up on the discussion board, and hopefully you all, at this point, have a better understanding of how to interpret odds ratios and relative risks. In the next video, we'll be discussing screening and whether or not it's useful, and how do we determine whether or not screening is really having an impact on health.